So I'm an anesthesiologist. People will ask and they don't really know what that means or what we do. Why would anybody know, right? Like my job is done while you're asleep. So I thought it would be interesting to just walk you through what the medical expression of my job looks like. So example, we'll say that I'm evaluating a patient who has low blood pressure after a procedure of some sort. There's a million procedures you can do. There's a million disease states. There are a million medications people can take. I have to figure out what's going on with that patient with like 4 vital signs. Clinical problems don't show up in terms of parameter A looks like this, B looks like that. Each presents as groups of symptoms. They are not thumbprints. They still are only patterns. So the doing of the job in my mind, it's not what you know, it's what you can deduce from what you know. So for that reason, it's important to have a thought framework. I'll try to avoid using too much jargon, but I'm also going to talk to you like a doctor a little bit. I'm actually very excited to be sharing this with you because I learned this as a medical student and I use it to this day. So what do we have now? We have a group of presently disconnected types of information. One, how does the patient look clinically to, we'll say, us? I'm there, you're there. What's the patient's medical history? What are the things that the doctors did to the patient, meaning the surgery and the anesthesia? And what are the list of potential problems that could occur that might be either related to those things or unrelated to those things? So we have these kind of 4 clouds and you need a way to organize them and get to where you gotta go. We can decompose the idea of low blood pressure into the physiological components of blood pressure and then individually consider the problems that can affect each of those components. And in that way, we can zero in or triangulate what the problem is. So in this case, we'll say it's a 30-year-old woman, young, no medical problems, just had her gallbladder taken out. The first step of breaking down the problem into smaller parts is to look at what makes up blood pressure. Blood pressure is a function of your vasculature's resistance, right? We call it systemic vascular resistance. It's basically the vascular equivalent of muscle tone. The resistance beds in your circulatory system are variable. Your blood pressure is a function of the resistance of your vascular bed times your cardiac output, how much blood your heart is pumping into that bed. Cardiac output is itself dependent on other smaller variables, right? So we're further chunking down the problem to its smallest, most manageable components. Yeah, so your cardiac output is dependent on your heart rate and how much blood your heart pumps per beat. Heart rate times your stroke volume. Stroke volume is the volume of blood ejected by the heart every beat, every stroke of the ventricle. Your stroke volume, though, can also be further broken down into the third equation of this kind of hemodynamic breakdown. Your stroke volume is made up of what we call the ejection fraction, right? The amount of blood that your heart beats per beat is a function of how much the heart fills, right? The volume of blood that is in the heart and what fraction of that volume your heart squeezes out per beat. Your heart does not empty every single beat, right? There's an end diastolic, which is diastole is the relaxation part of the heart where it fills with blood. And then there's systole, the contraction phase, where you squeeze out a certain fraction of blood. You don't squeeze it all out, right? So the normal number of your ejection fraction is 70%, 0.7. So there's the ejection fraction times whatever your end diastolic volume is. Whatever the volume of the heart's chamber, the ventricle is when it's maximally filled, right? Now, that number, the amount of blood that will sort of passively fill the heart between beats, that's a function of how much blood that you have. When your heart beats, it pushes blood forward, and there are valves that keep things going forward. But when your heart relaxes, it fills from the inertia from its last beat, right? So that means that it requires, one, that the beat is strong enough, but two, requires that there's enough blood to kind of carry itself into the heart for the next into the next beat. So that's how that is how and why your filling volumes, your end diastolic volume is reflective of how much blood your body has. So let's just go through each of these things and you'll see how they allow me to organize my thinking. The patient has low blood pressure. Mean arterial pressure is a function of your systemic vascular resistance times your cardiac output. Systemic vascular resistance. The first problem that comes into mind that affects systemic vascular resistance is sepsis, right? Sepsis is the presence of bacteria in the blood that causes the body to have a certain kind of inflammatory and defensive response, and the presence of the toxins cause abnormalities, right? So what that means is the patient looks a certain way, right? You can look at the patient and you can see evidence of sepsis, right? Other pieces of evidence would include a fever. The patient would have probably a high heart rate. The patient's history would have some reason to suspect. The history should have some reason to suggest that the patient has acquired a new kind of blood infection. In this case, easy rule out, next index. Right? Next index on our algorithm is cardiac output, which we said is a function of heart rate and stroke volume. So heart rate. Heart rate is itself a vital sign that we can directly observe, right? So that's an easy one. Problems that affect the heart rate primarily would be something like an arrhythmia, right? You can generally tell by one, the number is wrong, and two, the EKG is also, the tracing of the EKG is immediately visible, right? So that's a quick rule out. You just kind of look and see. All right, moving on from heart rate to stroke volume. Stroke volume is ejection fraction times end diastolic volume. Ejection fraction encapsulates the actual systolic, the contractile function of the heart. Whether the myocardium, the muscle of the heart, is failing, if the structural components, the valves of the heart, are failing, right? But again, when you consider those against the spectrum of what we know about the patient, right? 30-year-olds generally don't have heart attacks without some form of either history or severe deflection from what their normal baseline is, right? We just did a very basic surgery. So all of this leads us to the last parameter, which is end diastolic or maximal relaxation volume of the heart in between beats, right? And we said before that is reflective of the amount of blood in the circulatory system, right? The first is hypovolemia. Hypovolemia means a reduction in the absolute volume of circulating blood. That can be due to bleeding and dehydration. The second cause of a low end diastolic volume is a little bit trickier. It is normal volemic anemia, which means that a patient can bleed a bunch, but intraoperatively, the clinicians involved have replaced the volume of blood with IV fluid, which is a dilution of blood, right? To preserve pressure, the pressure that any fluid exerts against your vasculature depends on proteins being present inside of that blood. So on that, we've considered and gone through nearly all the possibilities, right? I mean, and so I ask you, in a admittedly leading kind of way, in a 30-year-old young patient who just had surgery, who's had an incision and had stitches placed, who doesn't show any clear signs of sepsis, who doesn't show any clear signs of an arrhythmia, who doesn't show any clear signs of a heart attack, and who has a low blood pressure and maybe physically is showing signs of needing to have a blood transfusion. Right. So in this way, you see that we never jump from I don't know to suddenly I know. right? It's not, you don't see a patient do some magical all panel of all labs that then tells you the answer, and then you just go from 0 to 1. That's possible, but the doesn't always happen. There's not a test for every single situation, and it's usually the slowest, least informed, least useful, um, and least easy to act upon way of solving a problem. Because while you're waiting for your lab to come back, the patient reserve, right? As time goes on, the patient, every problem begins to grow, and the effect of your eventual intervention starts to decline, right? Um, so you should never depend on going from I don't know to I know. You go from, if you have a clinical problem, the process is the answer or the problem can be a large number of things. And with each investigation or each question, it can be a smaller number of those things until you get to the top, 1, 2, or 3 things. So yeah, just a simple demonstration of like some small aspect of clinical decision making and problem solving. Hope it was interesting.